Thank you everybody for joining us today. We were having a little bit of technical, we're working out some glitches, so apologize for starting a little late, so we'll just get going. So first to start out, my name's Patty George. I'm a PH pulmonologist, Team PH athlete, and co-founder of Team Phenomenal Hope. And I want to thank you all for joining us for our first educational town hall as part of the Tour of Phenomenal Hope. We're just kicking off Pulmonary Hypertension Awareness Month. And so our first town hall is going to be a basic overview about what is pulmonary hypertension. And I'm super excited to introduce our speaker today. But before I do so, I just want to tell you a little bit about Team Phenomenal Hope and one of our featured programs. So Team Phenomenal Hope was created to bring together a worldwide team of individuals to build community and improve the quality of life for those living with pulmonary hypertension. To succeed in our mission, we embody the culture and spirit of endurance racing, and we bring together patients and caregivers, athletes, donors, supporters to raise awareness about pulmonary hypertension, as well as funds to support research and unmet patient needs. So this week is sponsored by our endurance program, where we bring together athletes who like to run, bike, swim, all of the above, or ski or walk or do any sort of physical activity, any sort of length, in a race to make a difference in the lives of PH patients. We pair up athletes with people who live with pulmonary hypertension in our Let Me Be Your Lungs program, helping inspire our athletes with every step of the way or every pedal stroke. You can find out more about joining our team in 2021 by going to our website, teamphenomenalhope.org. And if you join us now, or if you know somebody who wants to join us now for PH Awareness Month, we have a special Let Me Be Your Lungs challenge welcoming anyone to join us during the month of November. All the information is on our website. So with that, it's my pleasure to introduce today's speaker. Dr. Jean Elwing is a PH pulmonologist, professor, and director of the PHA accredited pulmonary hypertension program at the University of Cincinnati Medical Center. Not only is she an incredible physician who takes care of people who live with pulmonary hypertension with a true patient-oriented approach, patient-centered approach, but she also does clinical research trials and has contributed numerous scientific papers in pulmonary hypertension. And having heard her speak many times, she is known as an excellent speaker and teacher and has an ability to explain complex concepts so that we can all understand. So with that, I am pleased to introduce Dr. Jean Elwing. Dr. Elwing, thank you so much for kicking off our educational series today.
Oh, it's wonderful to be here. Thank you all, and thank you for listening. I hope that in the next several minutes, I'm able to break down pulmonary hypertension. This is PH 101. So what I hope is that we can better understand what this disease is at the end of this lecture, and really understand that it's a blood vessel disease of the lungs that needs medications for best outcomes. And this is a common condition that we see, but very uncommon in the rest of the world. So we know that it takes a little bit to get diagnosed, a lot of effort to go through this workup. So hopefully I can make it a little bit more clear. So when we talk about pulmonary hypertension and abnormalities, I think it's first most important to start what is normal. Well, your heart has 4 chambers, and many of you are very familiar with that. But it gets a little bit confusing on how the blood comes into the lungs and how does this hurt the right heart. So blood normally is coming through the system into the vena cava, either the superior vena cava from the top of your body or the inferior vena cava from the bottom. And then the blood flows to the right atrium, right ventricle, and out to the lungs. And usually it's flowing really, really easily. But in people with pulmonary hypertension, we find that that is quite different. So normal blood vessels are wide open. They are easy to open up and allow extra blood to flow. When you exercise, when Patty does one of her crazy things that I can't imagine ever doing, those blood vessels in her lungs open up. They allow tons of blood to flow through, but that is limited in patients like yourself that have pulmonary hypertension. Those blood vessels are narrowed. They're less distensible. and that causes back pressure on the right heart. So how do we get from the symptoms you have to the diagnosis? Well, we start with having some inklings. We've got to know about this condition. We've got to have it on our radar. And we ask you about things like fatigue and chest pain and palpitations, dizziness, lightheadedness, fainting. Those are some of our most serious side effects of having pulmonary hypertension. So when we ask you about them each time, just know that we're trying to figure out where you are and if things are getting better or if we're losing a little ground. So we want to track those symptoms over time. When we examine you, we're looking for signs of high blood pressure in the lungs. We listen to the heart really, really well to try to see, do you have signs on your exam that the heart is under stress and strain? Do we hear a loud second heart sound? When that pulmonary artery pressure is high, that valve closes really hard and we can hear it. And sometimes I feel like I can almost hear it and feel it on my eardrums. And we look if you're having a murmur from that high pressure. That's your tricuspid valve gets a little leaky because it's the pop-off valve for the right heart. And we can hear that on exam by a tricuspid murmur. So we're listening for that. We put our hand on your chest and listen and feel for a heave. Is your heart beating really hard? And we look at your neck to see how much fluid you have on the right side of your heart. So is it extra pressure, extra fluid? And sometimes we press on the liver to try to see if we can bring that out. And that's looking at the venous pressure in the jugular vein. So those are things that help us know how you're doing and give us some direction on what to do next. So when we have suspicion, we go on to additional testing. We look at EKGs, and that tells us how the electricity is working in your heart. We look at chest x-rays, and we look at our favorite echocardiogram. Sometimes we do a heart MRI that tells us about structure and function of the heart. And lastly, we do a heart catheterization that tells us where the pressures are, how high they are, and how much toll it's taking on the right heart. So echo, that's our favorite test to look for pulmonary hypertension. So what do we see on an echo? We see size, structure, and function. So it tells us how big the right heart is, how it's tolerating pressures, and we watch it over time to see if it's getting smaller and more normal shaped as we treat pulmonary hypertension. We can also estimate pulmonary pressures. As I said, estimate, because it's not a perfect test. It is taking how leaky that tricuspid valve is, what I mentioned earlier that we're listening for on exam, looking at how fast the blood is flowing back through that valve, and then with that data, getting you an estimated pressure. Not everybody has a leaky tricuspid valve, so sometimes we can't estimate the pressures at all. And some people, we estimate pressures higher than normal. So it gives us an idea, but we're not going to go to the bank with that number. I'm going to show you some examples of what we look at on echoes. So this is an echo, and we get to see all the chambers of your heart, but we're seeing them a little bit upside down. So the bottom part of the heart is on top, and the top part is down here. And we see how well it's squeezing. And what I tell patients when they're in clinic, I show them their echoes. I say, I want your right side of your heart to be smaller than the left side of the heart. And in this case, we see that the right side is bigger. So this person was quite sick with their pulmonary hypertension. On this part of the echo, we actually see a slice through the heart halfway through. And we're seeing fluid around the heart. And we're seeing that the left side, which is up here now on the top part, is bigger than the bottom part of the heart. So we want to say, yes, your right side is bigger and we need to work harder on the pulmonary hypertension. So we get to the final diagnosis of pulmonary hypertension through a right-sided heart catheterization. This tells us, yes, the pressures are high or low, and how significant is it? Is it really high? Is it taking a toll on the heart? And what do we do next to manage you best? So it can tell us a lot of information, and we do that test initially and in follow-up. So here, when we're looking at your right heart catheterization, we see all the numbers through this catheter. This is a Swan-Ganz catheter, has all these ports on it. And this is actually put through the body, through the vessels, and it floats through the system, and it can tell us what the pressures are every step of the way. And in addition to that, because of what it can measure in terms of temperature, it can tell us how well the heart is beating and moving blood. So a lot of information from this quite simple tool. And as I said, we take this catheter, usually through the neck or the arm. Now we're doing a lot of arm approach. We advance it, it floats with blood, and we can measure pressures all the way through the system. And in comparison to many invasive procedures, it is one of our safer procedures, but we do have to respect it. We don't do it every month or every 3 months. We do it when we need to, but definitely something very important to know exactly where we're starting and how you're responding to medications. So we diagnose pulmonary hypertension by the numbers we find. And we're looking at the pulmonary pressures and the average or the mean pressure in the lungs. If it is more than 20, you meet criteria for pulmonary hypertension at rest. If we're drilling down further and we say, we want to know what that's from, we want to look at the rest of the numbers. We want to know if there's fluid from the left side of the heart. We want to know if there's extra resistance in the vasculature. So we get a whole bunch of numbers from that procedure, and that helps us to know, yes, it is from this problem, or no, it is from a different problem. So if you have pulmonary arterial hypertension, what we have medications for, your average pressure is more than 20, you don't have high pressures from the left heart, and you have high resistance in the blood vessels in the lungs. So when we have that, we oftentimes ask many, many questions about associated illnesses. We know pulmonary hypertension can be associated with many, many things. So we have a whole myriad of questions we're going to ask you when we meet you. 5 major groups of causes. Is it from your left heart? Is it from your lungs? Is it from the true blood vessel problem in your lungs? Is it from old blood clots? Or is it a group of things we really don't fully understand? So these are all under the umbrella of pulmonary hypertension. What many of you listening have is pulmonary arterial hypertension or chronic thromboembolic disease. These are things that we frequently see in our pulmonary hypertension clinics, and we manage with medicines specifically designed to help you and your lungs. So another way to look at this is huge number of people. Third most common cardiovascular syndrome is elevated pulmonary pressures or pulmonary hypertension. Sometimes it's associated with the left heart, sometimes it's associated with lungs, and rarely it's associated with true blood vessel problems or old blood clots. We have to figure out these rare conditions, because if we don't, you don't do as well, you don't feel as good, and we put your heart at risk of getting worse. So that's why we have to sometimes play Sherlock Holmes and do what feels like a million tests to sort it out. So when we get pulmonary hypertension, as I said, big umbrella, we have the different forms, and we can break each one down into multiple causes. So we're going to start with group 1, the pulmonary arterial hypertension. This is true blood vessel disease in the lungs, and that's the kind we have many medications for. So if you have that form, we're going to ask you more questions, because we have many, many causes. Half of people that have this condition have no underlying reason that triggered it, but the other half may have gotten it from someone else in their family. Maybe they were exposed to medications or drugs in the past. Some people have connective tissue disease like scleroderma. Some have underlying HIV, liver disease, congenital heart disease, or in some parts of the world, schistosomiasis. So just know that we don't stop at group 1. We have to then drill down further and try to figure out, why do you have group 1 pulmonary arterial hypertension? And as I mentioned, many things cause, with half being no reason. Maybe 10 years from now, it will be smaller because we'll get smarter. But right now, half is idiopathic, and the other half is associated with conditions, with the majority being connective tissue disease. Connective tissue disease, most of the time, is related to scleroderma, followed by things like lupus and rheumatoid arthritis. And the other half are the things I mentioned, like congenital heart disease, HIV, drugs, toxins, and liver disease. So just to give you kind of a gestalt of what is driving the blood vessel changes in your lungs. So we have to look for all of those things. Why? Some behave a little bit differently. Some are more aggressive. And some we don't want to miss because there's things we can do to treat that problem, like underlying HIV, or if it's a medication we want to get rid of, or if it's your liver, we want to figure out what's fueling the liver disease. Okay, so now we got a sense. We know the symptoms. We know how to diagnose it. Well, how is it going to behave? Everybody comes in, and as you can probably see, I'm in clinic. I just finished clinic. I met some new pulmonary hypertension patients today. And biggest question is, how is this going to affect my life? Can I live with this? Well, that's our goal. We want to be able to make you feel as well as possible. But this is a disease that progresses over time if we don't try to stop progression with our medications. And the pulmonary vascular changes that we mentioned earlier will get worse if we don't do something. And with that, the pulmonary pressures will go up over time. So early on, there's just a little bit of blood vessel change. And over time, this changes and starts to stress and strain the right heart. We want to meet you when you're a little bit symptomatic. We want to know you when you are short of breath exercising. We don't want to meet you when you're short of breath sitting still, because that makes it much harder on you to get better. And it makes a situation where we have to be super, super aggressive all at once. But we can do that. We will do everything we can to make you feel better. But as I said, the more we can be aware of this condition, diagnose it earlier, the better. So the other groups, we've got to know about those, because if we don't understand those groups, we don't understand the first group. So group 2 is your left heart, the most common cause of pulmonary hypertension. This is extremely common and increasingly common as people get older. So something we see very frequently in our patients. It can be a weak heart, it can be a stiff heart, or it can be valvular disease. So the treatment for that is managing the left heart disease. Group 3 disease is related to your lungs. Could be COPD, could be sleep apnea, could be scarring in the lungs. But the treatment for that is treating the lung disease. We won't make you better if we don't manage your underlying lung disease if you have pulmonary hypertension from that. Group 4 is our chronic blood clot problem. We talked a little bit about this early. Very important to be aware of. We've got to look for this in every pulmonary hypertension patient because it has very different treatments. So it starts with a blood clot. And about 50% of people know they had it. 50% of people never knew they had anything happen related to blood clots. Some people fully get rid of those blood clots, and other people keep them. And I tell people they're like hoarders. They can't get more of them because they will just keep more of them. So we got to prevent additional blood clots. So just kind of gives you an idea. Some of us can clean out things in our body and other people can't. And we just have to make sure we don't accumulate more blood clots over time. And we do that by giving people blood thinners. We can diagnose this in multiple ways. One, oftentimes people go to the emergency room because they're short of breath or go to their doctor and they get a CT with contrast. And that tells us oftentimes that, oh, you have blood clots in your lungs and the pattern is such that it makes us think that they could be old. And then we start our investigation. This person has a blood clot. We normally see wide open blood vessels, and you see there's a big line in this one. That is a sign of an old blood clot because it partially opens up the blood vessel, but they're left with some residual roadblocks, and that causes stress and strain on the heart over time. And that's in multiple blood vessels in many of our patients with old blood clots in the lungs. So this is different than our pulmonary arterial hypertension that we talked about, group 1 disease, because that's all medication. We treat with all different kinds of medication to try to work on those tiny, tiny blood vessels. When you have old blood clots in the lungs, we can do medications. We can do angioplasty, where we put a balloon in and open the blood vessel up, or we can do surgery. And we pick which one based on where the blood clots are, your overall health, and what we think is the best for your condition. So you'll see here, there's 4 different kinds of old blood clots in the lungs. Big ones in the medium-sized vessels, smaller vessels, and the tiniest vessels. All of these people were very symptomatic, and all of these patients had them surgically removed. So many people can have them surgically removed, but for a lot of people, they're not surgical candidates, so we can entertain our medicines and the balloon angioplasty, or the catheter-based treatments, to try to open them up with multiple treatments. So just know, lots of options, but if you don't look for this, you will not find it. And patients won't do as well if we don't understand the underlying cause of the high blood pressure. So as I mentioned, we can do treatment with angioplasty, or small catheters that open up those blood vessels. And you can see the wonderful results here of a narrowed blood vessel from an old blood clot. You can see here's the blood vessel, and then it gets really, really tiny. And they were able to put a balloon catheter in there, open it up, and reestablish blood flow through that vessel. So you can clearly see that part of their lungs will be much, much happier getting the normal amount of blood flow after it's flowing normally through that lung. So with that, I think we do a recap. We have an individual, maybe you're like yourself, that's short of breath, or lightheaded, or chest discomfort with exertion. And on exam, we might find loud heart sounds or murmurs. Because of that, we go down the route of looking for why. We look at your echo and your chest x-ray and your EKG. And if there's concern, high blood pressure is there, we go to the right heart cath. We diagnose pulmonary hypertension. And in the process, we're asking why. Why is this happening to you? Why? Because we want to know about how we think it will behave, but we also want to know how best to treat you. Treatment for everyone is a lot of normal things that we do, like trying to get you to be more active. Make sure when you go on a trip that you do it safely. We discuss it. We make plans that you don't go to altitude right away. Denver's hard. Or you don't go really high up to altitude. And if you do, we've got to be ready. We've got to have oxygen. We've got to do everything we can to keep you safe. We've got to prevent illnesses. We've got to keep you safe from COVID. We've got to vaccinate you for normal things like flu and pneumonia. We strongly recommend women of childbearing potential don't get pregnant, because this is really, really hard on you. And we don't want to take any risk for your pulmonary hypertension to get worse, or you to get really sick during pregnancy. And we use contraception to prevent pregnancy, to prevent that risk for you. We use blood thinners in some patients with pulmonary hypertension, and we talk with you about this and figure out if you're the right person. Usually the people that have pulmonary hypertension for no reason, inherited it, or got it from a medication or a toxin, are the people we entertain, but not everybody gets blood thinners. We use water pills if you're swollen, and we use oxygen if you need it, if your saturations are lower than 90%. Now, we didn't talk anything yet about fancy medicines. Well, the fancy medicines come in when we do that heart catheterization. That tells us what route to go. We do oftentimes a challenge to see if the blood pressure would lower in the lungs. And we'll use calcium channel blockers in very special people that respond really, really well when we give them a medicine in the cardiac cath lab to test the blood pressure in your lungs. If you don't respond, or you're not the right person, we go on to special medicines that have been tested, designed, and studied long-term in pulmonary hypertension patients. And sometimes when you're really sick, or things aren't progressing the way we want, or it's been a long time that you've had pulmonary hypertension and we're just losing a little ground, we talk about lung transplant. And we try to make sure we know what you want out of your medications so we can adapt and do that. So we always have to balance what medicines we're doing, side effects, and try to get the most benefit and controlled side effects for you. So we have three main pathways we use for treatment. We try to block something that vasoconstricts, so we try to block endothelin. We try to dilate blood vessels through nitric oxide, and we try to dilate blood vessels through prostacyclin. We have lots of options for medications, so it's not easy. This is not something you can go to your primary care for and get medications for. Not because your primary care is not fantastic. It's because this stuff is a science within itself. And we want to make sure we give you the best mix that works the most effectively for you with the most tolerable side effects. So I mentioned that we use medicines in those three pathways. Our oldest pathway, and one I want to just mention because most people have lots of questions about this, is the prostacyclin pathway. It's our oldest pathway, our strongest pathway, and we can give it in multiple ways now. We can give it IV, as you can see here with a pump. This is an IV that's tunneled into the vessel in your upper body and giving you medicine 24 hours a day. There's no other disease that we think about using a lifelong IV medicine for. We do this because it works, and it works really well for a lot of people. There's another medication, treprostinil. We can do the same, but we can also give that under the skin or inhaled. We can also inhale iloprost. So those tools look very different. So this is the pump for IV medicine. It's a larger pump, but as I said, sometimes we have to go big, and this is what we do when somebody really needs extra help for their pulmonary hypertension. We can go smaller with the sub-Q medicine with treprostinil, and that's a smaller pump, fits in the size of your palm, or in the palm of your hand, and oftentimes a very nice option for people, and it doesn't require the indwelling IV, but it is continuous 24 hours a day medicine. And as I said, we can inhale medicine. This is Ventavis, 6 times a day inhaler. Not a free lunch, it's a lot of work, but there are people that it works very well for, and we just have to pick the right person. And we also can use an inhaler called Tyvaso. You might be on this 4 times a day. A little bit new research out on this medicine, so we're probably going to be using it a little bit more in our patients with lung disease over time. So exciting stuff for many people that have pulmonary hypertension with this device. So how do we follow this? We don't just start medicine and go on our merry way. So we follow you up in clinic. We discuss your symptoms. We do repeat examinations. I want to know what that tricuspid murmur sounds like. I want to hear that loud P2. We do walk tests. And one of my patients calls it the 6-minute marathon, but it is hard, especially when you start. And hopefully it gets easier and easier. We ask you about all those symptoms, like, are you short of breath when you dress? Are you short of breath when you take a shower? Because we want to know your functional class. And we do labs. And some of our labs are really important because they tell us about how your kidneys are working. They tell us about stress and strain on the heart. And they help make sure that we're not having significant side effects from your medicines. We do those echocardiograms, those baby ultrasounds of your heart, about every 6 to 12 months. And we're looking at the right heart size, function, and the pressures that are estimated by echoes. And right heart catheterizations, I'm a little bit lenient on these 1 to 3 years, or if you're feeling worse, then we do it right away, or if you need a surgery, something of that sort. So the plan that's right for you is the plan that's right for you. And I think that's what you have to remember. We are going to have a dialogue. Patty will talk with you if she's your doc. I'll talk with you if I'm your doc. And we'll try to make sure we understand what you want and how to fit the medicines with those goals. And we have to respect these medicines are strong and they're a big time investment for you, and they have side effects, but they're totally 1000% worth it if they make you feel better. This is a collaborative effort, and you are the most valuable player. So just remember that. We also have to really be mindful that you need support. This experience will be different for you than many other people that have pulmonary hypertension. So just know that when you get on the support groups and talk to people and you're struggling, you're like, why aren't they struggling the way I'm struggling? Everybody's different, and everybody will have different struggles throughout the process. Some of the things we do for people are the same, but they vary based on underlying conditions. So you might get confused by, why is that person getting those tests and I'm not? Because we're trying to really hone in on what you need to not do too much, but not to do too little. And remember, everybody needs help, and there are support in many ways. They could be your family, they could be your friends, it could be the Pulmonary Hypertension Association, or your local support group. Recognize you're not going to feel good every day. You sometimes will have pulmonary hypertension days. Don't be too hard on yourself. Understand that you're going to have some variability. When you're titrating up your medicines, you may not feel great. You've got to take time to rest, relax, and recuperate. Avoid situations that will push you over the edge and then lose 2 days after. And avoid situations that put your health at risk. Be mindful that we don't want you to get sick with an illness by pushing yourself to do things that you want to do but are not really worth the risk. And don't get frustrated with yourself. This can be complicated and confusing. So just remember, this is an extremely complicated topic, and sometimes it takes a little while to figure out what is going to work for you. The Goldilocks dose of medicine, or the Goldilocks medicines for you, may take a 2 or 3 times try. So before we end, I want to say thank you so much for listening, and I want to say thank you so much for the caregivers who are with you today, because their input and their help is so, so valuable. And I just want to say I really, really appreciate your time with me learning about pulmonary hypertension. So I'm going to open it up to questions, and I know that Patty may be having a few for me.
Thank you so much, Jean. That was a great talk, a great overview on pulmonary hypertension. I have one quick one from the Q&A box. Would it be okay for us to be able to get a copy of your slides to email out to the participants? Would you mind us sharing that?
Of course, I would love to share them.
Okay, great. Carl Hicks just said, very nicely done, and thank you so much for your presentation. So,
thank you. Thank you. Hi, Carl.
And I certainly want to echo that. As always, you just have a way of making it simple. And so that's just fantastic. I loved it. Let me think of a question while I'm looking to see if there's any more in the Q&A chats. When you talked about the different types of pulmonary hypertension, and what do you think you see most commonly? Do you feel like people neatly fit into these groups that we talk about? Or do you ever struggle with your patients because they kind of look like this and they kind of look like this? And then how do you decide and how do you make that personalized approach in that instance?
Okay, that's really, really important, because I think people do get mixed messages because of that. I think they go to their one doctor and they say, oh, it's your blood pressure and your fluid. And the next doctor is saying, no, it's your old blood clots. And the next doctor is saying, no, it's your antiphospholipid antibody syndrome. So I do think that that's one reason why you need a medical home. And that medical home will address all of those things that are happening. The problem is that when we get older, we get things like we get stiff hearts and we get AFib and we get maybe some COPD because we smoked a little bit, or we get some change in our body because of this, that, or the other. And we have to manage those things as well as the pulmonary hypertension. So do people most of the time fit in those nice 5 groups? No, but I try to figure out what I think is the predominant problem, address that, then add the other things on as I go along. So if you have bad blood clots in your lungs, I'm always going to play that game, and I'm going to treat that as aggressively as I can, because I know that's a big problem. If you have scleroderma, I'm going to treat you as pulmonary arterial hypertension, but manage the other things in the process. Does that make sense?
Yeah. One of the things we'll often see in our clinic, and I wonder if you can speak to how you approach this, is a patient will see their local cardiologist, or they'll see their local pulmonologist or internist. They get an echocardiogram, and the echocardiogram says something like pulmonary hypertension, and that's why they're sending them to you to work this up. But then the person themselves, they look online and then they see really dire like statistics. It like they're going to die in 3 years, or, you know, it's basically, I think, old data from, you know, NIH registry prior to when we had treatments, but that's like out there on a pretty prominent website because it seems to be something people carry in. And I know with our case, oftentimes just because they have PH on their echo does not mean that they'll end up having PAH, for example. So how, when you first see a patient, how do you approach it just to kind of help reassure them in that diagnostic process so they can sleep at night while they're undergoing this diagnosis and treatment? It's a serious disease, no doubt, but how do we cope while we're waiting for that diagnosis?
I truly think it's through education. And I love the flip book from the Pulmonary Hypertension Association. I take them through that book. And I talk to them about that this is high blood pressure in the lungs, in the small blood vessels in the lungs, but it has many, many causes. Regardless of the cause, we have to figure it out because they all affect your health long term. But if we treat, we can change the outcome. And I think that the most important thing is they don't get scared and that come back, because it is overwhelming. And we occasionally see people that maybe had an echo a couple of years ago, and then they were like so worried they never came to their appointment. And that's where we really lose ground. So we want to empower people with education and then have them be active in that evaluation. And then they can figure out how do we make this the best it can be. And I do say only look at stuff in the Pulmonary Hypertension website, because otherwise you're going to get misinformation that will get you down the wrong road.
Right.
And maybe get you over worried about things or worried about the wrong things.
Yeah, no, absolutely. I think that's great advice. You know, like you say, it's really going to the reputable source, and also talking, like having that educational appointment with somebody like yourself at the beginning. That's so key. Let's see, I have a question for you from one of our audience. He says, how high can I turn up my oxygen while on a treadmill to keep my SAT above 90? This might get into a little bit of medical advice, but
Okay, so I'll just give you some general advice here. So I always feel like in pulmonary hypertension, we are like the oxygen experts, because we deal with oxygen in all different shapes and forms. Bottom line is, I do think that this is something you should talk to your doctor about, but many times we have to do higher flow oxygen on a treadmill to keep your oxygen to the level it needs to be, because the treadmill is actually hard. And if you find that you can't keep your oxygen where you want it to be on a treadmill, try a different exercise machine like a new step. A new step is awesome because a lot of times people don't desaturate as much. I don't know if you've had that same experience for our patients, but
they'll use it in the rehab. Yeah, the new step.
Oh yeah. I've even had people buy them after they do rehab because they love them so much, because you can exercise without big desaturation. They're expensive though. But you could find some kind of like machine. So what I would probably do is do the qualifying walk or an oxygen assessment walk in pulmonary hypertension clinic to try to give yourself an idea, and then figure out, do you need more than a regular concentrator can give you, and get a higher flow concentrator if you need it, and then try some devices like oximizers to give you the most bang for your buck on oxygen. So those things I would ask your doc when you see them next, to figure out exactly how much oxygen you really need, and then adapt.
That's a really good point. Because if the doctor themselves may not know that somebody's at home trying to kind of push it, so to speak, and do that extra. So having that conversation is so key. That's awesome. Okay. Let's see. Another participant said, fabulous presentation. I'll echo that for sure.
Thank you.
I don't see any other questions here. So I'm just, I'll toss it out to the group real quick. If there's anybody else in the last minute that wants to say anything, you know, please holler now, or not holler, but put it in the Q&A. I'll check the chat box too.
Now, Patty, I will send you a PDF of the lecture, and then they can take a look at it at their leisure.
All right, fantastic. That'll be great. And we did record this as well, so it'll be out on social media in
Oh,
posterity, so that'll be really good. Um, and so I'm just looking to see if there's anything else. It doesn't look like it. So I wanted to, again, thank you so much, Jean, for giving this presentation. I wanted to also thank the people that helped make this possible, including from a technical standpoint, our colleagues at National Jewish Langdon and Nyla. Thank you so much for doing the hard work so that we could actually have this presentation today. And I want to thank our sponsors, our platinum sponsors, Janssen, Acceleron, and Bayer, and our gold sponsors, CVS and United Therapeutics, and also our silver sponsor, Altavant. Thank you all for helping us launch our Tour of Phenomenal Hope this month. We look forward to our next stages, and it should be great. The next talk is going to be a week from today, and we'll be talking with Dr. John Ryan, and he'll be talking with one of his patients, a person who lives with pulmonary hypertension, and they'll talk about empowering the patient with pulmonary hypertension. And so definitely make sure you check it out and join us. And with that, thank you all for joining. Have a great rest of your day.
thank you guys for having me. It was such a sweet thing. Thank you.
Bye. Thanks, Jean.
Oh, thank you.
Yeah.